Welcome to the Deep Dive. Today we're getting into something that touches so many lives, a cancer diagnosis. And we're looking specifically at what happens when that diagnosis involves an older person, maybe a loved one, maybe even you listening right now. It's a tough moment, often just a whirlwind of emotions, right? Fear, uncertainty, just feeling lost. And in the middle of all the medical terms, the tests, the treatment choices, there's this really basic human question that pops up. It's more than just the clinical stuff. It's, are we actually ready for this? For the whole journey?
Yeah.
Not just fighting the cancer, but, the treatment itself. It can be demanding, rough side effects, lots of unknowns. Are we prepared for that? So that's where we are today, looking at this really complex, really crucial area where oncology cancer care meets geriatrics, the care of older adults. Because, you see, when an older person gets a cancer diagnosis, the main question isn't only about the tumor, what kind it is, how aggressive, how far it's spread. I mean, that stuff is important, obviously. But the deeper question, the really vital one, it's about the person. The whole person.
It's about their own resilience, their body's ability to actually withstand treatment, which can be pretty tough. And maybe most importantly, does that treatment offer a meaningful extension of life? Something that really fits with their values, their quality of life, what matters most to them. Now, traditionally, doctors, quite understandably, they zeroed in on those cancer details. They'd look hard at the tumor, the scans, and then, based on the usual protocols, pick a treatment, often the standard one for that cancer type. But what we've really learned, especially for older patients, is that this way of thinking, well, it could be a bit of a blunt instrument, sometimes even misleading. Why? Because your age, just the number of birthdays you've had, it's actually a pretty poor predictor of how resilient you are, your body's reserves. Just think about it. You could have an 80-year-old who walks every day, maybe still active in the community, hypertension's well managed. That person is physiologically worlds apart from another 80-year-old who might be mostly housebound, dealing with heart failure, diabetes, maybe some memory issues. But if they both show up with the same stage 3 colon cancer, a purely tumor-focused approach might suggest the exact same aggressive treatment plan. And that just doesn't account for the huge differences between them, does it? It ignores so much about the individual. So our mission today in this deep dive is to explore what's really a revolution in how we predict outcomes for older adults with cancer. We're definitely moving beyond just the calendar page, beyond just age. We want to understand how these holistic, sort of multidimensional tools are now helping us quantify vulnerability. Not just the disease, but the person's overall strength. These aren't just acronyms, they're tools based on solid evidence. They give us a real snapshot of a patient's resilience, their potential weak spots, turning observations into actual data. And by doing that, they're empowering everyone, patients, families, doctors, to make genuinely shared decisions. Decisions that make sure the medical stuff actually aligns with personal values and, realistic outcomes, helping people live their best possible life. We'll be talking about tools like CARG, that's pronounced C-A-R-G, and the crash scores. They're really central to this big shift, moving from just focusing on the tumor to focusing on the person. Okay, so let's really unpack this shift. Let's see what's truly going on here.
It really is a fundamental rethink, isn't it? And frankly, long overdue in how we approach cancer care for older adults. The core problem, as you've laid out so clearly, is that those traditional models, the ones focused just on the cancer, they just don't capture the full picture of aging. They're great for understanding the tumor, yes, but they miss the cumulative impact of getting older on an individual's body. It's like they treat every patient with the same cancer as if they're identical, ignoring all the health conditions they've gathered over a lifetime, their unique resilience. It's like trying to plan a hike looking only at the mountain peak on the map, completely ignoring the rivers you have to cross, the valleys, the weather. You need the whole picture. And let's go back to that comparison you made, because it's so powerful, those two 80-year-olds. One is active, walking daily, maybe playing bridge, blood pressure's fine with one pill. Okay, the other mostly stays home, bad heart failure, diabetes isn't well controlled, maybe a bit forgetful, taking a whole handful of pills every day. Now, if both get diagnosed with the same stage 3 colon cancer, the old model looks at the cancer spec size nodes and says, okay, standard aggressive chemo and maybe surgery for both. But common sense tells you, and certainly geriatric medicine confirms, these two individuals are vastly different. Giving them both the exact same treatment completely ignores the huge differences in their ability to tolerate it, let alone benefit from it. For that second person, the more frail one, that standard aggressive treatment could easily cause much more harm than the cancer itself might have. It's such a clear reminder, isn't it? We're treating a person, not just a disease label. So what were those traditional models missing? Well, a few critical things. They didn't properly weigh comorbidities. That's just the medical term for other chronic illnesses someone has alongside the cancer, heart disease, kidney problems, lung conditions like COPD, diabetes, arthritis, you name it. Each extra condition adds complexity, puts more strain on the body systems, reduces that reserve capacity. They also often overlooked polypharmacy. That's simply using multiple medications, very common in older adults. Now, imagine you're already taking 5, 6, maybe more pills daily for different things. Then you add powerful chemotherapy drugs into that mix. The risk of harmful drug interactions or just side effects getting much worse, it goes way up. It's a chemical balancing act that gets much trickier. But maybe the single most important concept they often missed was frailty. Now, frailty, it's a word we use casually, but medically it's much more specific than just meaning old or weak. It's actually a clinical syndrome. It means someone has decreased physiologic reserve. Think of your body's resilience like a battery. When you're young and healthy, it's like you have a fully charged battery, maybe even with extra capacity built in. So if you get sick, have surgery, face a big stressor. You've got plenty of power and reserve to bounce back relatively quickly. But with frailty, it's like that battery is older. Maybe it doesn't hold a full charge anymore. It's partially depleted. There isn't much extra capacity. So when a big stressor hits like a bad infection, or critically for our discussion, chemotherapy, a frail person doesn't have that deep reserve. They can't bounce back as easily, or sometimes not fully at all. They're left really vulnerable to a much bigger decline in health than you'd expect from that stressor alone. And this isn't just a vague idea. This reduced reserve has real, concrete, biological reasons behind it that directly affect how someone handles cancer treatment. For instance, we often see altered pharmacokinetics in older adults. That's a fancy term for how the body handles drugs, absorbing them, moving them around, breaking them down, getting rid of them. Think about your liver and kidneys. They're the body's main processing plants for drugs, including chemotherapy. As we age, these organs might still work fine for everyday life, but they might not have the same peak efficiency as they did when we were younger. They can't always metabolize and clear those potent chemo drugs as quickly or completely. So what happens? A standard dose of chemo, one that a healthy 50-year-old handles okay, might lead to much higher levels of the drug circulating in an older person's blood for longer. It's like pouring too much high-octane fuel into an engine not built for it. It overwhelms the system, and the risk of severe side effects or toxicity just skyrockets. And then there's altered pharmacodynamics. This is about how the drug actually affects the body's cells and organs. Sometimes as we age, our spleen and organ systems can become more sensitive to a drug's effects. So again, that same standard chemo dose that a robust younger person tolerates with manageable side effects. In a frail older adult, it could trigger a whole cascade of serious problems. We're talking things like life-threatening infections because their immune system gets knocked down harder, or severe nausea and vomiting leading to dehydration, malnutrition, or just profound crippling fatigue that makes even getting out of bed impossible. This can spiral quickly, lead to hospitalization, sometimes long stays, and often, sadly, a permanent decline in function. Maybe they lose the ability to walk on their own or manage their personal care. And for many older adults and their families, losing that independence, that ability to live life on their own terms, that can be far more devastating than the cancer itself, especially if the cancer was slow growing to begin with. So what's really revolutionary about these new calculators is that they are designed precisely to look beyond just age and quantify this exact vulnerability. They turn that gut feeling about someone being frail into actual predictive data we can use.
That explanation, connecting the biological changes of aging, the pharmacokinetics, and the pharmacodynamics directly to treatment risk, that's incredibly clear. It really highlights why just looking at the cancer isn't enough, and why these newer approaches are so critical, especially for you, the listener, if you or a loved one are facing these decisions. So if we're moving beyond just the tumor and age, what's the framework? What's the foundation for getting this bigger, more holistic picture of someone's health? Where do these calculators even start? It sounds like there must be an underlying assessment method, and indeed there is. The research makes it very clear. The philosophical foundation, the sort of blueprint for these advanced prognostic calculators, is something called the Comprehensive Geriatric Assessment. The CGA. This isn't your average checkup. It's widely considered the gold standard of geriatric care. It's a really thorough, often multidisciplinary evaluation. Think of it as moving way beyond just lab values and imaging, beyond blood tests and scans, to ask really practical, deeply relevant questions about the whole person. It's about understanding the patient's life, their daily challenges, their strengths. Not just the disease, it's designed to give you, the patient and family, the most complete view possible.
Exactly. The CGA is called comprehensive for a reason. It systematically looks at multiple interconnected areas of an older person's life. And crucially, each of these areas, these domains, has been proven to independently predict health outcomes, like how well someone will likely do after surgery or how well they'll tolerate chemotherapy. It's like assembling a detailed jigsaw puzzle of that person's overall health and resilience. Each piece gives vital information. So, first, there's functional status. And this goes way deeper than just asking, can you walk? It looks at specific abilities, understanding exactly how independently someone manages their day-to-day life. We usually break it down into two parts. First are the activities of daily living, or ADLs. These are the real basics of self-care we often take for granted. Things like bathing, dressing, eating, using the toilet, and transferring, like getting from the bed to a chair. If someone is already struggling with these fundamental tasks before cancer treatment, that's a very clear sign of significant vulnerability. It tells us they're going to need a lot of support during and after treatment. Then there are the instrumental activities of daily living, or IADLs. These are a bit more complex, the tasks needed to live independently out in the community. Things like shopping for groceries, managing money, handling medications, cooking meals, using the phone, arranging transportation. Now, having trouble with IADLs is often a more subtle but really powerful early warning sign of vulnerability. Think about it. If you can't manage your finances easily, how are you going to keep track of a complicated chemo schedule, or co-pays, or bills? If preparing meals is already difficult, how will you maintain good nutrition when chemo makes you feel sick or tired? If you can't easily use the phone or arrange a ride, how will you get to all those appointments? These IADL issues strongly predict difficulties with sticking to treatment plans, managing pills safely at home, or even recognizing and reporting side effects early, all absolutely essential for safe and effective cancer care. Okay, next, the CGA carefully assesses comorbidities. Those are all the other chronic health conditions we mentioned: heart disease, diabetes, kidney issues, COPD, arthritis, maybe a past stroke. Each one adds another layer of complexity. The more chronic conditions your body is juggling, the less reserve capacity it has to cope with the huge added stress of cancer treatment. It's like your system is already working harder just to maintain balance. Then there's cognitive health. This is so important and sometimes gets missed. Even mild cognitive impairment, maybe subtle memory issues or difficulty with complex thinking, can seriously affect a patient's ability to give truly informed consent. Can they really understand the risks and benefits being explained? It can also make it hard for them to accurately remember and report side effects. They might forget to mention something crucial, delaying help for a potentially serious problem, or they might misunderstand instructions for taking medicines at home, the timing, the dose, what foods or other meds to avoid. This creates huge safety risks and can undermine the whole treatment. Imagine trying to follow complex chemo instructions if your short-term memory isn't reliable. It's a setup for problems. We also look closely at nutritional status. Being malnourished or even just borderline undernourished before starting treatment is a major red flag. It significantly impacts your ability to tolerate chemo, heal from surgery, and fight off infections. You need adequate calories, protein, vitamins. These are the literal building blocks your body uses for repair, for immune function, for energy. Without enough fuel in the tank, the body just can't cope effectively with the demands of cancer therapy. And we consider the psychological state. Things like depression, anxiety, or just feeling overwhelmed and hopeless. These aren't just emotional issues, they're medical conditions that can really affect someone's motivation to stick with treatment, keep appointments, or even report symptoms accurately. Addressing mental health is just as vital as addressing physical health for overall success. A positive, supported outlook can make a real difference. And finally, but definitely not least, is the patient's social support system. This is absolutely crucial. Does the person live alone? Do they have family nearby, friends? Community resources they can rely on. Who can help with rides to the clinic, pick up prescriptions, help with meals or chores if they're feeling unwell after treatment? Having a strong, reliable support network can make a massive, measurable difference in someone's ability to get through treatment successfully. Without it, even seemingly simple things can become huge barriers. It's the safety net that helps manage the practical and emotional load. Now, you might be thinking, wow, that CGA sounds like it takes a lot of time. And yes, a full formal CGA can be quite involved, sometimes needing input from different specialists like a physical therapist, a social worker, maybe a dietitian. But here's the clever part. The most powerful prognostic tools we're about to discuss. They're essentially distilled, validated, and much more user-friendly versions of the CGA. They cleverly pull out the most predictive, high-impact pieces from that comprehensive assessment framework. They streamline them so that they can be used relatively quickly and efficiently right there in a busy oncology clinic. The predictive power comes directly from this holistic, evidence-based foundation. It's why they work. So knowing that foundation, what does this actually look like in practice? What are these tools that are changing the game for prognosis and personalized care?
That's a fantastic overview of the CGA. It really paints a picture of how deep and wide that assessment goes. It's like creating this incredibly detailed, multi-layered map of a person's entire health landscape, not just the cancer peak. So the big question then is, how do you translate all that rich, detailed information from the map into something practical, something you can actually use quickly in a busy clinic to make decisions? What are these calculators, these instruments that take that deep understanding and turn it into, well, actionable guidance? Let's really dig into those key players now. Maybe start with the ones focused on predicting the risk of treatment, the toxicity, because knowing the potential downsides up front seems incredibly important for everyone involved, especially for you, the patient, and your family.
Absolutely. And probably one of the most influential, one of the tools that's really made waves in geriatric oncology because it gives such concrete, usable information is the ISEO-ARG chemotoxicity score. Remember, that's pronounced CAARG. This is really a landmark tool. Its main job is very specific. It predicts the risk, the percentage likelihood of someone experiencing severe side effects from chemotherapy. We're talking what doctors call grade 3 to 5 toxicity. So this isn't about predicting, mild nausea or a bit of fatigue. This is about forecasting the risk of really serious, potentially life-threatening problems before you even start treatment. Things like severe infections needing hospitalization, organ damage, debilitating fatigue that puts you in bed for days, or complications that could even be fatal. Knowing that risk up front is huge, how does it work? Well, it's actually quite elegant, especially for the clinician using it. They input a set of specific patient details, usually into an online calculator that's readily available. And what's really crucial for you, the listener, to understand is what information goes in. Yes, some of it is about the cancer, the type, and importantly, whether it's single-drug chemo versus multi-drug chemo, polychemotherapy, because using multiple drugs generally carries higher risk. But, and this is key, the vast majority of the factors plugged into the CARG score are distinctly geriatric. They come straight out of those CGA principles we just discussed. For instance, the CARG score asks for the patient's age. Now, we said age alone isn't the whole story, and it isn't, but it is still a contributing risk factor when considered with everything else. It asks about hearing impairment. That might seem odd, right? But think. If you can't clearly hear instructions about your chemo, or if you can't easily communicate subtle early side effects over the phone, that creates a real safety risk. It asks about recent falls. Falling before treatment is a huge red flag for underlying weakness, balance problems, just overall frailty. Someone falling before chemo is at much higher risk of serious falls once treatment causes fatigue or nerve damage known as neuropathy. It asks about difficulty walking even one block. That's a direct measure of functional mobility and endurance. It also asks if social activities have decreased because of health. This can be a subtle sign of declining energy, reduced physical capacity, maybe even early cognitive changes. It hints that reserves are low. And beyond those functional and social questions, it includes objective lab values too. Specifically, kidney function, measured by creatinine clearance vital because kidneys clear many chemo drugs, and hemoglobin levels, checking for anemia, which impacts energy and oxygen delivery. So you input all this data, and the calculator gives you a percentage risk score for severe toxicity, and this just fundamentally changes the conversation you have with your doctor. It's profound. Instead of the old question, what's the standard treatment for this cancer? The question becomes much more personal, much more focused on you. It becomes, okay, given your specific health profile, what is your individual risk of being seriously harmed by this standard treatment? It forces a shift from a one-size-fits-all approach to a truly personalized risk assessment. It puts you at the center. And there's another important tool that works similarly and really reinforces these ideas, the CRH score. That stands for Chemotherapy Risk Assessment Scale for High-Age Patients. Like CARG, its main goal is predicting severe chemotoxicity. And it also uses a smart blend of cancer factors and geriatric assessment factors, again, driving home how critical these non-cancer details are. CARG specifically looks at things like the patient's performance status that's often measured using something called the ECOG score, a standard scale rating how active someone is, from fully active to bedridden. It also includes measures of cognition, sometimes using tests like the mini mental state exam. It assesses nutritional status. And crucially, it brings back those instrumental activities of daily living, the IADLs we talked about, shopping, managing meds, finances, again highlighting their importance for predicting how someone will cope. The fact that we have two separate, well-validated models, CARG and CRASH, both developed independently and both heavily emphasizing these geriatric factors, well, that proves a really critical point. It tells us, loud and clear, that an older patient's functional status, their cognitive health, their overall physical resilience, These things are at least as important, and maybe even more important, than just the stage of their tumor when it comes to predicting how their treatment journey will go. That's a powerful message for you as a patient or caregiver to hold on to. Your overall health, your whole picture, matters just as much as the cancer diagnosis itself.
That's incredibly helpful to understand. So we've got these tools, CARG and CRASH, giving us a clearer picture of the potential harms, the toxicities of treatment. That's huge for safety, for making informed choices. But often, the questions go even broader, don't they? Patients and families are grappling with, okay, realistically, how much time might I have considering all my health issues? And how will this treatment affect the quality of that time? That feels like a different dimension of prognosis. Are there tools that help address that bigger picture, looking at overall life expectancy, maybe even mortality from things other than the cancer?
You've absolutely nailed a critical and often very sensitive aspect of this. Prognosis isn't just about the immediate risks of treatment. It's also about understanding the bigger timeline, especially the chance of dying from other health problems. And that's exactly where resources like ePrognosis become invaluable. Now, ePrognosis isn't just one single calculator. It's better to think of it as a curated library, an expert-vetted collection of many different validated prognostic indices, mostly developed by the Geriatrics group at UCSF, University of California, San Francisco. It's a really robust, constantly updated resource. The real beauty of ePrognosis is its flexibility and its focus on the whole person. A clinician can go there and choose the most appropriate calculator based on the individual patient's situation, their age, their specific health conditions, whether they live at home or in a nursing facility, etc. So for instance, if you have an older patient with several significant comorbidities, maybe serious heart disease, plus advanced lung disease, plus kidney problems, there are specific tools within ePrognosis, like the Lee-Schonberg Index, for example. This index helps estimate their likelihood of dying from causes other than their cancer over a specific time frame, maybe in the next 1 year, 5 years, or even 10 years. It looks at their overall health burden. And getting that information is absolutely crucial for making truly informed, patient-centered decisions. Why does this matter so much? Let's paint a picture, a very common scenario. Imagine a man, maybe in his late 80s, diagnosed with a low-grade, slow-growing prostate cancer. Now, for this type of cancer, especially in an older man, active surveillance, basically, watching it closely without immediate aggressive treatment, is often a very reasonable, evidence-based option. Many of these cancers grow so slowly, they never actually cause harm. But, historically, without clear, objective data on the person's overall prognosis, there might have been pressure, maybe even from the patient or family, to do something aggressive like surgery or radiation just because it's cancer. But what if this same man uses a tool from ePrognosis, like that Lee-Schonberg Index, and it shows he has a pretty high chance of dying from his severe heart disease within, say, the next 3 to 5 years? Suddenly, the whole calculation changes for him and his family, doesn't it? The potential harms and side effects of aggressive prostate cancer treatment, and they can be significant, like incontinence, impotence, bowel problems, things that really impact quality of life. Those harms might now clearly outweigh any potential benefit. Why endure those debilitating side effects, the recovery time, the potential loss of function to treat a cancer that probably wasn't going to be the thing that limited his lifespan anyway? It helps put the cancer in the context of his total health picture. So these ePrognosis tools provide the objective data needed to confidently recommend and for patients to comfortably choose strategies like active surveillance or maybe less intensive therapies focused purely on quality of life. They allow doctors to say, based on evidence, look, considering your overall health, your likely lifespan from other conditions, and the slow nature of this cancer, the best path for you might be to manage this conservatively. Let's focus on maintaining your quality of life, your independence for the time you have, rather than risking serious harm from treatment that likely won't help you live longer or better. Clue. It's about sparing patients unnecessary harm, aligning treatment with their actual prognosis, and crucially, supporting their goals for how they want to live. And here's where it gets really interesting. The real power isn't just in spitting out a number.
That is such a crucial point. Shifting from just fighting the cancer to optimizing the quality of the life the person has. It makes so much sense. So it's definitely not about these calculators being some kind of, fatalistic fortune-telling device. Their real strength, as you're saying, isn't just the prediction itself, it's how they're used. They're tools for shared decision-making. So a high score on CARG, for instance, isn't a command to just stop treatment. It's not therapeutic nihilism. No, it's more like the research says, a flashing yellow light, a warning sign, a prompt to pause, think harder, and have a much deeper, more personalized conversation with you, the patient, and your family.
Exactly, precisely. A high-risk score should never be the end of the conversation. It should be the start of a more nuanced, more compassionate, and frankly, more human one. This is really where the art of medicine has to meet the science of prediction. The doctor's role goes way beyond just typing data into a website and reading off a percentage. It involves taking that, let's face it, potentially scary number and translating it into a meaningful discussion, one that truly considers the patient's individual values, their fears, their hopes, what quality of life means to them. And how you frame that information is absolutely critical. Let's take that example. A 40% risk of severe toxicity from the CARG score. If the doctor just says you have a 40% risk of severe side effects, well, that sounds pretty bad, right? It could feel discouraging, maybe make someone want to refuse treatment altogether. But a skilled communicator, someone really attuned to the patient, might frame it differently. They might say, okay, this assessment suggests about a 40% chance of serious side effects. That also means there's a 60% chance you'll avoid them. Let's talk about what those potential side effects are, what that 40% risk means to you, and importantly, what steps we can take together to maximize that 60% chance of doing well. See how different that feels. It sounds more hopeful, more collaborative. It empowers you to think about prevention and management, not just to focus on the fear. A good clinician presents the data neutrally, here's the risk, here's the chance of avoiding it, and then explores what it means for this specific person. Is avoiding severe toxicity the absolute top priority, even if it means choosing a less potent treatment? Or are they willing to accept higher risks for a better shot at cure? That's where your personal priorities, your values, become the deciding factor. And there's another layer here. These tools can actually turn a risk score from a passive number into a launchpad for a proactive care plan. They create what we sometimes call a teachable moment. That high-risk score. Instead of just being bad news, it becomes a trigger. A catalyst for specific, targeted interventions before treatment even starts. This is where that whole CGA foundation really pays off. So, for example, maybe the CRAG or CRH score is high partly because of poor physical function or borderline nutrition. That doesn't mean stop, don't treat. It means, okay, let's intervene now. It might trigger an immediate referral for prehabilitation.
Prehabilitation, like rehab, but before.
Exactly. Think of it like training for a marathon, but the marathon is cancer treatment. You work with physical therapists, maybe occupational therapists, to build strength, improve endurance, work on balance before you start chemo or have surgery. Maybe it's exercises to prevent nerve damage from chemo. Maybe it's balance training to reduce fall risk. It's about boosting your physical reserves as much as possible beforehand. Or that high score might trigger an urgent consult with a dietitian. Let's optimize your nutrition now. Make sure you have enough protein, enough calories, the right nutrients to give your body the best possible resources to handle treatment, fight infection, and heal. Or maybe it flags a need for more support at home. So an immediate appointment with a social worker to figure out transportation, maybe meals on wheels, maybe connecting with local support groups, bolstering that social support system we talked about. So you see, in this way, the calculator becomes much more than just a predictor. It becomes a diagnostic tool. It identifies the specific vulnerabilities it measures and then prompts us to actively address them. It completely reframes the conversation. It's not about limitations, about what you can't do. It becomes about optimization, about support. Okay, what can we, the whole healthcare team, do together to give you the very best chance of getting through this successfully? It creates a sense of partnership, of proactive care, not just risk prediction. And we absolutely have to acknowledge the psychological side of this. Receiving a number that quantifies your frailty, your risk, that can be really confronting, maybe even scary. It's deeply personal. So that information must be delivered with empathy, with compassion, and always coupled with a strong message of partnership and proactive planning. The goal is never to frighten someone away from treatment that could help them. The goal is to empower them with knowledge, and then use that knowledge to build this comprehensive scaffold of support all around them: physical, nutritional, social, emotional support, giving them the absolute best chance to navigate treatment with dignity, maintain their independence as much as possible, and ensure the whole process aligns with what they define as a good quality of life.
That shift you described from just predicting risk to proactively managing it, building that scaffold of support, that's incredibly powerful. Feels like such a hopeful, patient-centered evolution in care. It really underscores that these tools aren't about limiting options, but about optimizing the journey for each individual.
Wow, what a deep dive this has been. We started with that often overwhelming moment of a cancer diagnosis in an older adult, and we've journeyed through to understand how medicine is really making strides in personalizing care for this exact situation. We talked about that crucial shift, moving away from focusing only on the tumor to really embracing the whole person, their unique resilience, their vulnerabilities, the complexities of aging. And these tools we discussed, CARG, CAR, CRASH, the resources within ePrognosis, they're so valuable. not just because they predict risk, but because they pinpoint vulnerability. And that knowledge allows doctors, patients, and families to anticipate problems, to mitigate harm, to turn risks into opportunities for proactive support, like that prehabilitation idea.
Ultimately, they equip you, the listener, whether you're the patient or a caregiver, with clearer information, objective data to help make those really tough decisions that truly honor personal values, independence, and life goals. It's about finding the path that's right, not just for the cancer, but for the whole person, ensuring the treatment fits the life, not the other way around.
That's exactly right. By carefully considering and quantifying the whole picture function, other illnesses, cognition, support these calculators help us move beyond guesswork. They usher in an era where cancer care for older adults can be truly precise and personalized. They help make sure that the treatment plan isn't just some standard protocol pulled off a shelf for a disease label. Instead, it's meticulously tailored step by step to the unique individual who is living with that cancer. The ultimate aim is always to support the person, their independence, and their quality of life throughout their cancer journey.
So perhaps the final thought for you to take away is this. The next time you or someone you care deeply about is facing a complex medical decision, especially where age and other health issues are involved, maybe ask the question, how are we making sure we're looking beyond just the diagnosis, beyond just the tumor? How are we assessing the whole person to create the best, most truly personalized plan possible for you? Thank you so much for joining us on The Deep Dive.